You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about hypertensive urgency and emergency. We'll start with definitions, then talk about targets, then talk about preferred agents, then discuss contraindications, side effects, and some use notes. Let's get started. Hypertensive urgency is defined as blood pressure of at least 180 over 120 or higher without end organ damage. They may have mild headache, but that's still a hypertensive urgency. Hypertensive emergency is blood pressure of 180 over 120 or higher with end organ damage. So what counts as end organ damage? We look at 5 systems: neuro, ophtho, heart, lungs, heme, and nephro. For neuro, is there hypertensive encephalopathy, severe headache, altered mental status, PRES, TIA, or CVA? For ophtho, you look for any papilledema, bilateral flame-shaped retinal hemorrhages, exudates, or cotton wool spots. For heart and lungs, you look for any pulmonary edema, any MI, positive troponin, angina, or aortic dissection. For heme, look for any mmHg, hemolytic anemia. For nephro, look for any AKI or hematuria. What's hypertensive encephalopathy? That is when you have blood pressure of 180 over 120 or higher with seizures, lethargy, irritability, confusion, cortical blindness, stupor, or coma without an alternative explanation. Hypertensive encephalopathy occurs due to failure of cerebral autoregulation, with dilation of cerebral arterioles leading to excessive cerebral blood flow and damage to the arteriolar wall with increased vascular permeability. Hypertensive urgency patients should not be sent from the clinic to the ED as it causes more hospitalizations without improved MACE or hypertension control. Now let's move on to targets. In cardiogenic pulmonary edema, acute MI, pheochromocytoma crisis, acute sympathetic discharge post-carotid endarterectomy, and acute intracranial hemorrhage, you need to reduce systolic blood pressure to 140 or lower within the first hour, and then keep it there for the next 24 hours. The exception for acute intracranial hemorrhage is that if there is a large hematoma or high intracranial pressure, then you reduce systolic blood pressure to 180 or lower within the first hour instead of 140 or lower. In acute ischemic stroke with plan to give TPA, to avoid causing intracerebral hemorrhage for TPA, you need to first bring down systolic blood pressure to less than 185 over 105 prior to giving TPA, then permit the blood pressure to hang out there at less than 185 over 105 until 24 hours to perfuse the penumbra. That's permitted hypertension. I know everyone else calls it permissive hypertension, but from a linguistics perspective, I feel strongly that this should be called permitted hypertension because you are permitting the hypertension. It's not the hypertension's permitting something else happen. You, the physician, are permitting this hypertension. So let's call it permitted hypertension. All right. In acute ischemic stroke with plan to not give TPA, if blood pressure is more than 220 over 120, then reduce MAP by 15% over 1 hour to avoid cerebral edema exacerbation or hemorrhagic transformation. If blood pressure is less than 220 over 120, then don't give any antihypertensives. Just permit blood pressure to hang out there at less than 220 over 120 until 48 to 72 hours to perfuse the penumbra. Again, this is permitted hypertension. In hypertensive encephalopathy and diffuse microvascular injury, you need to reduce MAP by no more than 25% the first hour, then down to 160 over 100 or lower for hour 2 to 6, then after 6 hours, gradually lower it to the outpatient goal. Diffuse microvascular injury refers to hypertensive emergency that has the end organ damage of high-grade retinopathy, hemorrhages, exudates, or papilledema, AKI, thrombocytopenia, or microangiopathic hemolytic anemia. There's only one condition where the goal is to bring down the systolic blood pressure to 160 or lower in the first hour. That is severe preeclampsia or eclampsia. In addition, the diastolic blood pressure needs to be lowered to 105 or lower in severe preeclampsia or eclampsia. Then keep it there. The only definitive treatment is delivery of the baby. The most stringent one is acute aortic dissection. Within just 5 to 10 minutes of presentation of acute aortic dissection, you need to bring down systolic blood pressure to 120 or less, and you have to bring the heart rate down to under 60, then keep it there. Those are the different targets for acute blood pressure control in hypertensive urgency and emergency. Now let's go over the preferred agents for blood pressure lowering. In acute aortic dissection, start with esmolol or labetalol. If systolic blood pressure remains over 120, then an intravenous dilator such as sodium nitroprusside is recommended for further lower arterial pressure. Although you probably will need both, the beta blocker should precede the use of the vasodilator, such as nitroprusside IV or nicardipine drip, or else you will get reflex tachycardia. In cardiogenic pulmonary edema, start with nitroglycerin plus a loop diuretic plus or minus BiPAP. Alternatives are nitroprusside or clevidipine. Nitroglycerin is first line in cardiogenic pulmonary edema because it rapidly decreases preload and also provides rapid symptomatic relief. Beta blockers will actually worsen acute cardiogenic pulmonary edema and should be avoided. So don't use labetalol or esmolol in hypertensive emergency related to cardiogenic pulmonary edema. In hypertensive emergency related to acute MI, start with nitroglycerin. Alternatives are esmolol, labetalol, and nicardipine. Check that the patient did not take a PDE5 inhibitor within the last 24 hours because nitrates given with PDE5 inhibitors may induce profound hypotension. Beta blockers are contraindicated if there is moderate to severe LV failure with pulmonary edema, bradycardia less than 60 beats per minute, hypotension less than 100 systolic, poor peripheral perfusion, second degree or third degree heart block, or reactive airway disease. In pheochromocytoma crisis or acute sympathetic discharge post-carotid endarterectomy, start with phentolamine, which is a reversible non-selective alpha blocker. Alternatives are calcium channel blockers such as nicardipine or clevidipine. Benzodiazepines should be given before trying blood pressure control. For concurrent tachycardia, use a combination alpha beta blocker such as labetalol. Don't use beta selective antagonists such as atenolol, esmolol, or metoprolol when you're dealing with pheochromocytoma crisis or acute sympathetic discharge post-carotid endarterectomy. In severe preeclampsia or eclampsia, start with labetalol, hydralazine, or nicardipine, plus IV magnesium. These medications are safe in pregnancy. In contrast, ACE-ARB, renin inhibitors, and nitroprusside are contraindicated in pregnancy. In acute ischemic stroke, start with labetalol or nicardipine. Calcium channel blockers and beta blockers are first line in stroke because they don't raise intracranial pressure, unlike nitroprusside. Nitroprusside will vasodilate the large cerebral veins, worsening the intracranial pressure. In acute intracranial hemorrhage, start with nicardipine. Alternatives are clevidipine, labetalol, or hydralazine. Nicardipine and clevidipine are preferred because it has the least blood pressure variability, thus has improved outcomes in patients with acute intracranial hemorrhage. Nitroprusside will vasodilate the large cerebral veins, worsening the intracranial pressure, so should be avoided in acute intracranial hemorrhage. In hypertensive encephalopathy and diffuse microvascular injury, the two conditions where your target is reducing MAT by no more than 25% in the first hour, start with labetalol, nicardipine, or nitroprusside. Avoid IV hydralazine. Patients with no hypertension-mediated end organ damage should not be given IV or drip medications. They should instead be treated with oral antihypertensives such as captopril, labetalol, or nifedipine, or by adaptation of their current agents. Rapid blood pressure lowering in these patients is harmful. Next, let's go over contraindications, side effects, and use notes of IV drip antihypertensives, starting with nicardipine drip. The onset of the nicardipine drip is 5 minutes. The dose is 5 milligrams per hour, increase every 5 minutes by 2.5 milligrams per hour to a max of 15 milligrams per hour. Contraindications to nifedipine drip are advanced stenosis, aortic stenosis. It is first line in stroke, but calcium channel blockers don't raise intracranial pressure unlike nitroprusside. Side effects of nicardipine drip are headache, nausea, vomiting, tachycardia, all because of vasodilation. Nicardipine is safe for pregnancy. Clevidipine drip has an onset of 1 minute. The dose is 1 to 2 milligrams per hour, doubling every 90 seconds until the blood pressure target is reached, then increase by less than double every 5 to 10 minutes. The maximum dose is 32 milligrams per hour. Contraindications to clevidipine are soy or egg allergy, pathologic hyperlipidemia, or acute pancreatitis. It needs to be stopped before 72 hours. The max duration of clevidipine is 72 hours. Clevidipine, just like nicardipine, will also give you headache, nausea, vomiting, tachycardia, all because of vasodilation. Next is nitroprusside drip. Nitroprusside onsets in 5 seconds. The dose is 0.3 to 0.5 micrograms per kg per minute, increasing by 0.5 to the blood pressure target. The max dose is 10 micrograms per kg per minute for nitroprusside. Contraindications include MI because nitroprusside causes coronary steal and will worsen the MI. That's why we don't give nitroprusside. If needed, we give some sublingual nitroglycerin or we give a nitroglycerin drip, but not nitroprusside for MI. Also, increased intracranial pressure is a contraindication because nitroprusside will vasodilate the large cerebral veins, worsening the intracranial pressure. The duration of the nitroprusside drip should be kept as short as possible. If the dose is 4 to 10 or more than 30 minutes, give thiosulfate to prevent cyanide toxicity, which involves irreversible neurologic changes and cardiac arrest. Liver patients cannot detoxify cyanide. Next is the nitroglycerin drip, which onsets in 2 minutes. The dose is 5 micrograms per minute, increased by 5 every 3 to 5 minutes to a max of 20 micrograms per minute. Nitroglycerin drip is contraindicated in volume depleted patients because nitroglycerin vasodilates. It's usually used only in ACS or acute pulmonary edema. These are the opposite of volume depleted states. Nitroglycerin rapidly decreases preload and also provides symptomatic relief rapidly in both MI and acute pulmonary edema. The side effects are tachyphylaxis, so you may have to keep increasing the nitroglycerin dose, which is not an ideal situation. Next is esmolol drip, which onsets in 1 minute. The dose of esmolol is 500 to 1000 micrograms per kg over 1 minute, followed by 50 micrograms per kg per minute infusion. Esmolol is contraindicated by existing beta blocker use, bradycardia, or decompensated heart failure. High doses of esmolol may block beta 2 receptors and affect reactive airway disease. Next, we have labetalol. Labetalol onsets within 2 minutes. The dose is 0.4 to 1.0 mg per kg per hour IV infusion, up to 3 mg per kg per hour. Adjust the rate up to a max total cumulative dose of 300 milligrams of labetalol in a 6-hour period. Labetalol can also be given as an IV push, 0.3 to 1.0 mg per kg dose, max of 20 milligrams that will slow over a slow IV injection every 10 minutes. Contraindications to labetalol include reactive airway disease, COPD, bradycardia, decompensated heart failure, second degree or third degree heart block. Labetalol drip is especially useful in hyperadrenergic syndromes, and it is safe for pregnancy. Then we have phenaldipam drip, which onsets in 10 minutes. The dose is 0.1 to 0.3 micrograms per kg per minute, increasing by every 15 minutes by 0.05 to 0.1 until you reach target blood pressure. The max dose is 1.6 micrograms per kg per minute infusion. Phenaldipam is contraindicated by glaucoma and increased intracranial pressure and sulfite allergy. Indications, side effects, and use notes of IV push antihypertensives. Hydralazine push onsets in 10 minutes. The dose is to inject 10 milligrams via slow IV infusion of hydralazine and then repeat every 4 to 6 hours PRN. Hydralazine is safe for pregnancy. The drawback is the unpredictability of hydralazine's response, and the prolonged duration make it not a first-line agent. Also, you will have rebound tachycardia. Phentolamine push onsets in 5 seconds. The dose is 5 milligrams IV injection every 10 minutes PRN. It is used in catecholamine excess, pheochromocytoma, Maui interaction with food or drugs, cocaine toxicity, amphetamine overdose, cocaine withdrawal, and post-carotid endarterectomy. Side effects of phentolamine are flushing, headache, and rebound tachycardia. Then you have the enalaprilat push, which onsets in 15 minutes. The dose of enalaprilat is 1.25 milligrams over a 5-minute period, and you can increase up to 5 milligrams every 6 hours. Enalaprilat is contraindicated in pregnancy, MI, and bilateral renal artery stenosis. It is useful in high plasma renin activity. Enalaprilat has a slow onset of action, 15 minutes, which is the slowest among the IV push antihypertensives such as hydralazine and phentolamine. And enalaprilat also has an unpredictable blood pressure response. Now, we've gone over a lot of different things in terms of medications for hypertensive urgency and emergency, as well as the definitions and the thresholds. So, I want to just briefly finish by talking about cocaine hypertensive urgency. The half life of cocaine is 60 to 120 minutes, so it lasts 4 to 7 hours in the body. Cocaine has increased inotropy, increased chronotropy, and increased peripheral vasoconstriction. So that's why it has so many cardiovascular side effects. The treatment for cocaine is nitrates, calcium channel blockers, benzodiazepines, and or phentolamine. Combined alpha and beta blocking agents such as labetalol can be used provided the patient has a vasodilator such as nitroglycerin or calcium channel blocker within close temporal proximity. So that's everything for this episode on hypertensive urgency and emergency.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.